Now we're going to continue a little bit on the same theme, but in a different model, human models, I think, and see what some of this basic research how it interacts with some of the clinical settings. So Barbara is from Scripps as well, and she's going to give us another 2 hours of. Welcome, Barbara.
Thank you. So I didn't know that George was going to show this, so here it is in my talk. It actually was used in a grant application that we put in to develop parallel human and animal laboratory models. And as George mentioned, the goal is to kind of reduce some of the disappointments that happen in the large-scale, expensive, lengthy clinical trials that are the gold standard for moving drugs through the FDA approval process, and creating this way station of the human laboratory model to use what we learn about a drug in the animal models, run it through a parallel human laboratory model, and develop kind of a snapshot of the drug and how it will relate to the real world applications. So George and I published our thinking about this kind of process. George calls it the Rosetta Stone approach, where all the work that's done with a given drug in the animal and human laboratory models are kind of plugged into a grid that I'll give you a little example of in a moment, showing whether a drug showed a signal in alcohol administration versus Q reactivity versus stress-induced, etc. And that kind of gives you an idea of the mechanism of action of a drug and how it's likely to perform in the real world. So I see alcoholism and the addictions as having 3 opportunities for medication development. Traditionally, medications in alcoholism have been used in the acute withdrawal phase, which lasts up to 5 days and is pretty well covered by benzodiazepines, so that's not a phase of particular interest. The binge intoxication phase is a phase that has been addressed early on with Antabuse, which was approved in 1949, believe it or not. And then naltrexone, which was originally approved for opiate addiction and then was reevaluated for alcohol dependence. And more recently has been approved in a long-acting injectable formulation to get around problems with noncompliance. Because believe it or not, neither rats nor some humans actually enjoy having their endogenous opioid system under blockade. So there has been some issues. There have been some issues there. The phase that's of particular interest to us is the post-acute withdrawal, protracted withdrawal, or protracted abstinence phase, where the stress systems are recruited. And clinically, we see manifestations of this as insomnia, which some people even consider a biomarker of relapse, dysphoria, anxiety, irritability, and craving. And so acamprosate was the first medication, the only medication approved for alcohol dependence that acts in this part of the cycle. This is a little piece of that Rosetta Stone that I referred to earlier. Alcohol self-administration and Q reactivity are 2 of the models that have been used most commonly in human laboratory studies to assess effects of drugs in alcohol dependence. Stress-induced craving is a model that's getting more traction, but Rajita Sinha is really an expert in this, so I'm not going to address this because you'll hear it from her later. So, with acamprosate, that drug that acted in the protracted abstinence phase, you did get a positive signal in human laboratory models involving Q reactivity. You got negative findings in models involving self-administration. And the majority of the clinical trials were positive, 18 of 23 as of last count. Yes?
Can you explain what reactivity is?
Oh, I'm going to explain it in great detail. Just bear with me for a minute while I lay out the concept of the Rosetta Stone. Gabapentin is another drug that we hypothesize acts in that protracted abstinence phase. And likewise, it showed a positive signal in Q reactivity, negative findings in alcohol self-administration, positive findings in clinical trials. So this is like good. This is what you want to see. You want to see human laboratory models used that accurately line up with the outcomes of clinical trials. These drugs down here are more hypothesized to act in that binge intoxication phase of the cycle. So these are drugs that you would expect to see being active in alcohol self-administration models and not necessarily in Q reactivity models. Q reactivity is the hyper-responsiveness that alcoholics show when, for example, exposed to their favorite alcoholic beverage. Olfactory cues are particularly powerful. And so you're looking for a medication that modifies that responsivity as a protection against relapse in that early abstinence phase. Whereas alcohol self-administration models might use mini drinks or actually pumps to actually inject alcohol to see if a drug suppresses self-administration of alcohol. And that's something that you expect to see in drugs that act in the binge intoxication part of the cycle. And when you think about that cycle, the brain is in very different conditions in each one of those three phases. If it's being bathed in alcohol or a drug of abuse, it's in a very different phase than it's when it's undergoing acute withdrawal. And that's a very different phase than when you're in protracted abstinence and the stress systems are recruited. And like drug manufacturers are very impatient, like, well, why does a person have to be abstinent in order to take this drug? Well, if they're not abstinent, then the stress systems aren't recruited, that the drug is hypothesized to treat and thereby prevent relapse. So you really need abstinence if you're using a drug to treat protracted abstinence. Otherwise, you don't have abstinence, so you don't have the pharmacological target. So what's important down here is when rimonabant, which is a CB1 antagonist, and the endocannabinoid system is certainly involved in the reinforcing effects of drug. And when you had an antagonist that blocked that system, like naltrexone blocks the endogenous opioid system, and it did not show efficacy in a human laboratory model of alcohol self-administration, that was like, uh-oh. But nonetheless, the drug company went ahead with a very large multi-center trial, and that was a complete bust. So this is actually a good thing for the Rosetta Stone, because this is what you want. As well as you want drugs that predict true positives, you also want drugs that predict true negatives, you know, to save that big expense of the large, especially multi-center clinical trials. So that's kind of the thinking behind it. And the thinking behind my work is to look at novel medications for relapse prevention during that protracted abstinence post-acute withdrawal phase. And we need alcohol-dependent subjects as opposed to social drinkers, because it's in dependence that you do have that neuroadaptive process that involves the recruitment of the stress systems that George talked about that form the pharmacological target for preventing relapse by normalizing hyperactivity in those systems. And so the method that we use is affective priming, which I'll explain the reason behind in a moment, and cue reactivity as a model of risk factors for relapse and protracted abstinence. So if you think about it, think of an alcoholic, dependent on alcohol, has been withdrawn. You think about how vulnerable they are, even walking by the door of the bar, but particularly the sight, smell, other cues associated with an alcoholic beverage, especially their favorite alcoholic beverage, that's a risk factor for relapse. Also, different emotional states. Alan Morlatt originally, but many others have also replicated, are risk factors for relapse. Being angry is one. Being sad, especially for females. And for males, positive emotional states like at sporting events, romantic encounters, these can all be times of disinhibition that are associated with alcohol use. So what we try to do in the human laboratory model is to create these different conditions and see if the drug that we're studying reduces the vulnerability to relapse under these common situations. So now, these are the details about cue reactivity, probably more than you ever wanted to know, but it's what makes it useful. It was originally developed, and the methods that we use in these human laboratory studies were originally developed to understand alcohol per se, not to investigate the efficacy of medications, but rather the effects of alcohol. And so it's the response that alcoholics exhibit to alcohol cues that differ from the way they respond to non-alcohol cues. And in our studies, we use bottled spring water as a comparison. You can measure it through self-reports, and we use a couple of very quick visual analog scale items because we don't want to give them pages of papers to fill out where you've completely lost the effect of the cue. And physiological measures like skin conductance and heart rate, which are general measures of arousal, but also facial smiling and frowning muscles we find to be fairly specific to the cues, so we find them to be quite useful. It's more intense in alcoholics than non-alcoholics, understandably so, and that's good because you want a good strong signal that you can measure drug effects on. And what's also important is that it's been associated with subsequent drinking. The craving that is induced in response to the cues has been found to be a predictor in our lab and others of how alcoholics will then go on and behave in the real world in terms of relapsing to drinking after an abstinent interval. Okay, so it's an important marker. Now, one problem that you have with alcoholics is they come into your lab and, it's a soundproof room, no windows, because you want to keep the stimuli focused on the cues, right? Well, you don't really experience peak craving in that kind of a situation. So one thing that we do is what's called affective priming to kind of try to induce some of those angry or upset mood states or high euphoric mood states, to kind of create a disinhibited state that makes you more receptive to the alcohol cues, because you want a strong signal to measure change in. And the cue reactivity offers the alternative to the alcohol self-administration paradigms, which is a really important proof of concept test for drugs that are hypothesized to prevent relapse by normalizing the dysregulation and the stress pathways that George talked about earlier today. So, as I mentioned, we want people who have current alcohol dependence because these are the individuals who do have the stress system dysregulation. And we have them abstinent for 3 days before the Q reactivity testing because we want them to be, you know, like in a state ready to be responsive to their favorite alcoholic beverage. And they have to be non-treatment seeking because we are exposing them to alcohol cues that may make them more likely to drink. And we pay them because they're doing it for the money. They're paid volunteers to participate in the project. And we've done a lot of work developing this model. Even though we use the techniques that have a long tradition in studying alcohol, to study the techniques to detect drug effects, originally we thought, oh, we'll do a within subjects design, you know, put them on drug, wash them out, placebo, or the reverse in random order. But what happens with Q reactivity is you get one bite of the apple. There's no baseline and follow-up because repeated exposures to the cues decrease the responsivity so that time becomes a more important effect than whatever drug you're studying because the timing of each subsequent exposure reduces the Q reactivity. So you have to do parallel group comparisons of your drug, placebo, and so people are randomly assigned. We do very quick visual analog scale assessments with just a click of the mouse so that we keep them in the Q-induced state. And they are in a lazy boy lounger with the electrodes attached to the corrugator and zygomotor muscles and the skin conductance, heart rate measures. And we do various safety measures before they take the drug and when they finish. And it's like the first visit of a clinical trial in that you can do exploratory measures before they take the drug and after the drug, depending on how you think the drug will work. Sleep is something we often measure because it's so closely tied to that recruitment in the stress systems, and it's such an important factor contributing to relapse. Some medications work on cognition, improving the effects of alcohol, cortisol. There are many factors that influence cognition in alcoholism that can be improved with a medication. So we can do those pre-post kinds of measures in addition to the measures in the actual lab. We do chronic administration of the drug because you don't want to get the effect of side effects. Also, drugs take time to reach steady state. They often go through a cascade of affecting additional neurotransmitter systems. So we like chronic dosing, typically a week. It takes about an hour and a half to get the patient set up to go through the different conditions. And then they come back 1 week off drug to complete safety evaluations and to determine the persistence of any drug effects. So this is how we induce the different affective states. They're in the lazy boy lounger about here, and there's a big flat screen in front of them where images from the International Affective Picture System are projected. And this is a group of many hundreds of images that have been rated by many hundreds of undergrads as to the intensity of their positive negative state and various dimensions of affect. And so we originally chose the most negative, the most positive, and the blandest neutral. And we do 12 images from one affective state, and the subjects are just asked to look at each picture and try to feel the mood evoked by the picture. And we were getting good craving to the positive images, which were romantic encounters and sporting events, and less than we expected with the negative. And then we realized that romantic encounters and sporting events are associated with alcohol, but war scenes and, you know, the grisly things that were rated as most negative in the negative condition weren't necessarily associated with alcohol. So we modified them to domestic violence and car crashes and things, and then we got good cravings. So we also do hard copies of the photos afterwards and ask subjects periodically to sort them into piles of negative, positive, and neutral, just to verify that we really are inducing the affect we think we're inducing. And then after they get one set of 12 pictures, they get either their preferred alcoholic beverage or spring water right on a table right under their nose, so they get the good olfactory cues, and they're asked to just look at it, smell it, you know, it's there for 90 seconds and not to drink it. And 90 seconds is a long time. I've been the subject in this for many a trainee, and 90 seconds is a long time. A long time you're relating, you know, when you're not doing anything other than focusing.
How often do they drink it?
I'm sorry?
How often do they drink it?
They don't. They're paid volunteers.
I see.
They don't get paid if they drink it, and we make that very clear up front. And they're getting $100 for this one, so they don't drink it. Then they're asked one question. It comes up on the screen like that, and they just click, you know. And each question is derived from a factor of craving. It's the most informative question from the alcohol craving questionnaire, which has 4 factors. The strength of craving, the impulse to use, the control over the impulse, and the relief you would get from drinking. And that's it, because like I said, we don't want to dilute the mood. And these are the confirmatory measures, but they're much less specific than the actual craving questions. But as long as they're going in the same direction as the answers to the questions, that's what's important. And then, as I mentioned, we often look at sleep, and the Pittsburgh Sleep Quality Index is a self-report that's considered like the standard instrument, and it has these 7 subscales. So basically, you just repeat all the different combinations, or 6 possible combinations of affect and beverage, and collect the measures. After each one, the physiological measures are running continuously. And what we found in a Q-reactivity study with the Commercialization is that 20 subjects will give you 80% power for a 2-tailed test at a p.05 level of significance. That's 20 subjects per group. So that's a very reasonable sample size, and you can really move things along and get a lot of information about how a compound affects individuals with alcohol dependence in this kind of format. So the first medication that we were interested in studying was Gabapentin, A, because it was available and it's so time-consuming dealing with a drug company. You could spend more time trying to actually secure the material transfer agreement than you spend actually conducting the study. So to have something that's available that kind of acts in the way that you're interested in, and that we hypothesized it would act in that protracted abstinence phase. Marissa Roberto at Scripps showed that it normalizes GABA-CRF interactions in the amygdala in alcohol-dependent rats. She also showed that it dose-dependently reduced alcohol intake in dependent rats, and it had no effect on drinking in non-dependent rats, which supports that it's actually doing something that is specific to dependence and not just generally affecting drink consumatory behavior. It's been looked at off-label for different symptoms that are of interest in protracted abstinence, like depression, anxiety, and insomnia. It's used widely in medicine, and it has a very good safety and tolerability profile. But it had been studied in 2 human laboratory models and found to not have an effect. In one study, it was used in normal subjects. Now, normal subjects would not have the recruitment of CRF and stress systems that we were hypothesizing gabapentin would normalize in alcoholism. So we weren't worried about that. And it takes 7 days to reach steady state, so a single dose didn't shake us too much either. And then in another study, it was given for a week, but it involved alcohol administration. And now if you're hypothesizing that a drug is going to normalize GABA-CRF interactions related to abstinence, and you're giving them alcohol, we didn't consider that to be an acceptable test either. And combined with Marissa Roberto's promising findings, we decided to go ahead and do a human laboratory study of 1,200 milligrams a day. I basically called up the medical officer for gabapentin at Pfizer and asked what dose they would recommend, and they said, if you don't get a signal at 1,200, you probably won't. So with 1,200. And 1 week of administration, and then the Q session. And what we found was that relative to placebo, these are your placebo levels of craving, gabapentin reduced the strength of craving, the impulse to use, and reduced the feelings of loss of control over the desire to use. We also, yes?
Would those reductions be enough for them to not want a drink at that point? Like if they were in a situation where they were taking the drug and then something was placed in front of them, that they would say, I don't need it, I don't need to drink it.
In some cases, yes. And I'll show you the data for that after our break. Yes?
A couple of questions, Barbara. If you go back to the previous slide, so, no, the forward. There you go. What do you do to control for compliance, right? This is kind of a huge issue where studies were just thrown in the garbage can because patients just didn't take the drugs. What in general do you think about this issue, and what did you do in this study to control for that?
Okay. What we always do is we give the medication in a blister card that shows the time of day and the day that each dose is to be taken. They must return the blister card in order to proceed with the Q reactivity testing. And we also obtain a blood specimen for plasma level determination of gabapentin retrospectively. I mean, we don't look at that until the study's completed. We do it in a batch, but that's how we retrospectively determine. And in another study I'm going to show you later that involves an increase in cortisol when you give the meds, that was another excellent confirmation that drug was on board. So, there's a variety of ways, but those 2 methods, return blister card and plasma level determination, are always done to determine compliance.
Okay. Perfect, Barbara. Thank you. Second question. If you were to show patients one by one, do you see that because of the error bars, do you see that there is a spread? Do you see kind of a bimodal distribution of 2 clusters of them? What's your feeling? In other words, does gabapentin work more or less in most of them, or do you basically see yes, no, with a little bit of gap in between in general? Just if you remember that.
What happened in this, what you're seeing on this slide is a collapsing of the 6 conditions. Okay, so it's looking at the effects of drug versus placebo, across positive, negative, neutral. And you can also separate it out and look at gabapentin on positively induced craving or negatively induced craving. And we did that. And so that accounted for most of the difference, that gabapentin seemed to have its biggest effect on the positively induced craving. And that's what made us, these data in fact, are what made us go and look at those pictures and say, what's it about the positive versus the negative? And we thought about it. Actually, it was my daughter who said that. You know, these pictures don't have anything to do with drink. And so then we adjusted the pictures, and now we are very comfortable collapsing across the affective conditions because they tend to equally induce the craving. But a lot of the difference here is because of the difference in level of craving that was induced by the positive versus the negative stimuli. That was the big one there. Yes?
Similar question. Was there any difference between the men and women in terms of efficacy?
No, there wasn't. We always, this is another thing we always look at, is difference between response in males and females, and we have yet to get a differential effect between males and females in a drug that we've studied, which I think is interesting because with naltrexone, which acts really more on the positive reinforcing aspects of alcohol, for the most part, you do get differential effects. You know, it's been published both with the injectable form, which was shown only to have efficacy in males, and a study that was done entirely in females did not show a separation between naltrexone and placebo. So your question is you know, an important one. And also we did a meta-analysis of over 6,000 participants in the acamprosate randomized control trials and got absolutely no difference between males and females. And that's another drug that acts on the recruitment of central glutamate in protracted abstinence. So it's kind of interesting. Among maybe the 6 drugs that I've studied now in protracted abstinence, we've not had a sex difference. But we keep looking. Okay. So, also, CRF and REM density are not good buddies. So we always look at sleep quality, and what we found with gabapentin are beneficial effects in terms of sleep efficiency, which is the proportion of time that you spend lying down in bed that you're actually sleeping as opposed to lying there looking at the ceiling. So there was an improvement in sleep efficiency, sleep latency, that's the amount of time it takes you to fall asleep once you lie down. Sleep quality was quite improved with gabapentin, and then the overall global index of sleep quality was improved. So consistent with what you would expect with a medication that is shown to normalize the CRF-GABA interactions in the amygdala in dependence models, and in animals we got a nice effect in humans as well. And the FDA has published guidance for human laboratory studies and for clinical trials to look for a signal for abuse potential in any medication you study. And I do that. This is just one part of it, because I come from the era of when only anti-abuse was available, and that was a very punishing agent, so that was good and okay. But alcoholics were commonly prescribed benzodiazepines, so they would come into treatment with one dependence and emerge with 2 dependences to alcohol and benzos. And so medications got a very bad rap, and we're coming out of that now. And I don't want us to ever fall back into that trap, because it really prevents people from getting the treatment they need, whether it's specifically for the addiction or for comorbid psychiatric disorders. So we always look for signals for abuse potential, whether it's people losing their medication packets and needing them to be replaced, or there are certain questions that you ask about euphoria and, what drug liking, etc. But this is an old instrument that has, it's like a questionnaire about similarities to other commonly abused drugs, and there was no signal there for gabapentin. So what our study showed was that relative to placebo, with gabapentin, you had significant decreases in craving, improved sleep, good safety and tolerability, no evidence of abuse potential. And we concluded that a randomized controlled trial to evaluate the efficacy of gabapentin for alcohol dependence was warranted. However, this study was done when I was at the University of Miami. I then moved to Scripps in Southern California. And there was a big difference in the rate of cannabis dependence in California, where it is essentially legal, relative to Miami, where it was like New York. It was there, but it wasn't there, like it was in San Diego. And we thought about it. And, cannabis dependence and withdrawal has a lot of similarities to alcohol. And the protracted withdrawal symptoms are very similar in terms of sleep, craving, mood, etc. So we decided to take what we learned and also look at it in cannabis dependence. And I will show you the alcohol dependence data, but I wanted to show you the cannabis because it came first. Very similar rationale. Fernando Rodriguez de Fonseca, and Rodriguez de Fonseca is the last name. Fernando is the first name. It's very long. Anyway, he showed that very similar effects were found in the amygdala in terms of the GABA-CRF interactions in animal models of cannabis dependence, like in alcohol dependence. Oh, and the other thing is, there's a study by Zelinsky that was done to look at cognitive functioning, placebo, gabapentin, and topiramate. And the purpose was to use gabapentin as an active control to understand the cognitive deficits associated with topiramate, which is another anticonvulsant like gabapentin. And what this neuropsychologist in my lab, who's very detail-oriented, went into the online supplemental material for the article where they actually had the tables of data and found that certain aspects of cognitive functioning were actually improved with gabapentin relative to placebo, that it actually had some beneficial effects, not just, no difference. In fact, there were some improvements. So, we thought particularly in cannabis-dependent individuals, this could be an asset because that's a whole other story. But executive function deficits are an issue, particularly in people who start in their teens and become daily users right up through their 20s when executive functions are developing. So we decided we would conduct a small, it was a proof of concept, randomized controlled trial. We had an R21 from NIDA, which allowed us to study 50 individuals with cannabis dependence to look at whether gabapentin would decrease cannabis use, reduce the severity of cannabis withdrawal, especially those symptoms of insomnia, dysphoria, and craving, and improve marijuana-related deficits in executive functions. Particularly cognitive flexibility, inhibition, working memory, and selective attention. Because what we found is that the cannabis users are great as long as it's a really simple task. Like, are you familiar with trail making? It's like a connect the dots. If they have to go connect A to B to C to D, no problem. But if you start having some interference conditions, like they have to go A1, 2, B, 3, C, mixed numbers and letters, that's when you see a decline. It's that sort of process. So we had no idea what would happen. We didn't know if anybody would want treatment for cannabis. We knew there were a lot of cannabis users, so we put this advertisement in the local free paper, and waited to see what would happen. We got 743 phone calls, and we had 50 slots. However, what I would like to point out to you is, of those 743 phone calls, 350 were never found again. Of the ones that we scheduled for an intake eval, 9 didn't show up. And of the ones that we randomized to our precious 50 slots, let's see, 7 randomized to placebo, never showed up after the randomization visit. 3 that were randomized to gabapentin never showed up after the randomization visit. So, inhibition of impulses is one of those executive functions that possibly never developed adequately. Now, these folks differ from human laboratory folks because they're really treatment seekers. But otherwise, you know, the same age range, in this case, meeting criteria for cannabis dependence. We said that they had to have smoked marijuana at least once a week in the 90 days prior to randomization. Everybody was smoking every day. But, you know, it was our first study. You know, that's what our 21s are for. We learned about it. And they had to be willing to attend, you know, 12 weekly study visits and 1 follow-up visit. Little did we know how flighty they were. And, you know, basically we had very liberal exclusion criteria, just any serious medical or psychiatric condition, including dependence on other substances or being on other drugs. And we didn't want anybody who had to be in treatment because the court sent them. Also, I have to tell you that we said we wouldn't admit anybody who was being treated with medical marijuana, thinking that that would be a conflict. Well, everybody has medical marijuana cards in Southern California, and so that's not necessary to exclude them on that basis. So we had double-blind randomization to 2 arms, either the 1,200 milligrams a day or matched placebo. ONTO, compliance verified by return pill count and drug plasma concentration. It was a 12-week study, and they also got weekly individual counseling. And our measures were of marijuana use, and we used both a standardized self-report that's been quite validated. It uses a calendar format to help people recall, and like, oh, it was a Saturday. Does your use on Saturday differ during weekdays? You know, in holidays, birthdays, you know, that kind of thing. And then we also collected observed urines to look at the level of THC and metabolites in the urine. So that was marijuana use. Marijuana withdrawal, there's a withdrawal checklist, craving questionnaire, the usual Pittsburgh Sleep Quality Index, and the Beck Depression Inventory to capture some of the negative affect that we thought might accompany protracted abstinence as well. And we use the DLS-Kaplan Executive Function System. So this slide shows you the urine and self-report measures of use. Gabapentin's in green, and you'll see, and the lines are urine. So you'll see that the urinary concentration started out at quite the same level, but gabapentin went down and stayed down, such that for the last 4 weeks of the study, there was no evidence of new marijuana use. By self-report, gabapentin, prior to randomization, the week of screening, reported using more marijuana than placebo. But then you'll see at randomization, the following week, it had got down below placebo and stayed down. And then in terms of the effects on the subjective symptoms of protracted abstinence, the marijuana withdrawal checklist is a validated checklist of marijuana symptoms that encompasses some of these others. But you'll see, marijuana has a very long half-life, as you probably know. Like, you can test positive in your urine for up to 30 days after your last use, you know, especially if you're a regular heavy user. So the withdrawal in marijuana has never been like a big issue because you kind of slide off it. but that doesn't mean that people don't feel stimulated to treat the symptoms with marijuana, especially sleep and anxiety are big ones. So you can see how the withdrawal in the placebo group, goes up and then starts going down, as the drug goes away. But with gabapentin, you avoid that peak discomfort associated with the withdrawal symptoms. And you can see how gabapentin had quite a noteworthy effect on sleep. And one way, this is the placebo group, one way of understanding its effect, on the Pittsburgh Sleep Quality Index, a total score of 5 is generally associated with clinically significant sleep disturbance. So, with the placebo-treated people up around 10 for weeks of the study, that gives you a sense of how significant the sleep disturbance is. And also, if I had to choose in terms of the craving and mood symptoms, I'd rather be on the gabapentin than the placebo too. And this is from baseline to week 4 improvement on the executive function tasks. And the blue lines show improvement with gabapentin. The green lines show that the placebo either stayed the same or in some cases worsened on the various tasks. And also there's this scale called the marijuana problem scale that looks at functional problems related to marijuana use. And even after this very limited treatment, the gabapentin group did show a significant reduction from baseline in functional problems, which is nice to see. You don't often see an improvement in functional problems. But because dropout is such a problem with these marijuana patients, we looked at all the baseline measures to see if we could come up with what is associated with dropout so we could try to head it off at the pass. And what we found was that problems with executive function and severity of marijuana dependence were the two uber issues that really drove the early termination, the flying off never to be seen again, and you can't really do a whole lot about that. But I think that the executive function deficits is something that really needs to be looked at carefully, whether there are pharmacological interventions or cognitive retraining interventions, maybe using like video game kind of formats or whatever it takes. It's a real issue, and that bears further scrutiny in this population. It was very well tolerated. The drug didn't differ from placebo. The rate of medication was quite high. No differences in the length of study participation. So overall, we found that relative to placebo, gabapentin significantly reduced cannabis use. Withdrawal symptoms, especially the ones involving craving, sleep, and mood, showed a signal in improving executive function. This was a tiny group, so we can't tell you whether that drug was acting directly on executive function, as it did in the Selinsky study of normals, or because it was improving sleep, which included improvement in daytime dysfunction. It contributed to improvement, but nonetheless, it did have beneficial effects there. So, pulling Fernando Rodriguez de Fonseca's data together with ours, you can conclude that cannabis discontinuation in individuals with cannabis dependence is associated with protracted dysregulation of brain stress systems. There are protracted motivational systems for relapse, very similar to other drugs of abuse like alcohol, involving craving, insomnia, and negative affect. And in fMRI Q-reactivity studies that I didn't show you here, we also showed heightened salience of cannabis cues relative to like garden salads and houseplants, even after 28 days of abstinence in the cannabis-dependent subjects and the executive function deficits. The baseline severity of cannabis dependence, withdrawal, and impairment in executive function predicted treatment dropout. So these are very important issues to address early on. And that significant reductions in cannabis use and withdrawal symptoms lend support to the efficacy of gabapentin as a treatment for cannabis withdrawal independence. And we are doing a larger replication study right now. And these positive findings for gabapentin lend support to a neuromodulatory approach as an alternative to the agonist or antagonist approach to the treatment of cannabis dependence that's often taken in substance dependence, you know, a replacement drug or a blocking drug. This is a drug that rather acts on systems that science has shown do become dysregulated, and using a pharmacological agent to try to restore normal functioning in those systems. And it gives you a good example of moving from the behavioral studies in animals to human laboratory to early stage clinical trial. And I have good feelings about the larger stage replication study. So, yeah.
Is there any adaptations to gabapentin so that you get an enhanced, you stop it, an enhanced syndrome?
No. What Chris is asking about, is there any rebound in symptoms or negative effects to stopping gabapentin? We titrate people off. We titrate people on and titrate them off. We use the same titration off schedule in reverse that we use to titrating them on, and we get no rebound. And we followed people for 6 months in alcohol after their last dose without any evidence. We see them the week after and, you know, less frequently thereafter. But I think titration is important. Titration
So
off.
Do you think, how does gabapentin work? Do we know?
Well, one of the nice things about it is that it's a dirty drug.
That's what I thought.
Yes.
I just want to continue the question. Do you believe that this effect of gabapentin might be contributed by release of enkephalins, by some enkephalins?
By enkephalins?
Yeah.
George, what do you think?
I believe it works on L-type calcium channels. That's its primary action. It also increases the release of GABA. And no one knows how that is. Some people think GABA B agonist affects. Others say that that still happens in GABA B knockout mice. I've never heard
I've never heard enkephalin either.
the opioid connection.
No.
But the main thing is that I believe
Calcium
it's an L-type
Yeah.
calcium channel blocker. So
Because you think you slowly one before
to the type channel subunit, but it
Alpha
doesn't
2
affect the
delta.
activity of the channel.
yeah,
So it's a mysterious.
So the GABA effect seems to be, practically speaking, the primary effect as far as we know. But you're right, it's a dirty drug and it binds to probably many more things than we know.
So at least in the pain literature, it looks like they think the primary effect is through its actions on that alpha 2 delta 1 voltage-gated calcium channel auxiliary subunit.
Mm-hmm.
And so I would hypothesize that even the GABA increasing effect is probably a calcium channel dependent effect, like you said on one of your slides.
Mm-hmm. And what's interesting also is that a camprosate is thought to act by calcium channel active action. So, you know, they're very similar drugs, actually.
It's
Yes,
a
Mark?
very interesting channel because that's thought to be one of the key channels right at the presynaptic terminal. But nobody knows what the activity of this drug is. I mean, it binds with high affinity to that subunit, but it's not clear that it has any functional effect on the
So it definitely affects the trafficking of the channels. I don't know if that would be what it is. I guess we have a sort of cat hypothesis that we're going to maybe look into, that it could be affecting like morphological plasticity, because there's one paper showing that there's this astrocyte secreted protein thrombosbondin that is an endogenous ligand for alpha 2 delta 1, and that leads to excitatory symptom formation both during development and if there's some kind of injury in the brain.
Sounds cool.
Yes.
Did you say you took into account consideration age of first use of marijuana?
Okay, did we take into consideration age of first use? It's something that, you know, we did look at and we did report. It's been published in Neuropsychopharmacology last year. Age of first use is very important in terms of the neurocognitive effects, not so on the treatment effects.
And just because gabapentin, I mean, teenage years are the inhibitory controls and coming on board. And if you're using gabapentin just enhances GABAergic activity, you may get different efficacy, but you know that once someone who started using it as a teenager versus someone who started in their 30s. Like this.
All of our subjects are adults, so, you know, they are what they are at this point. But what we found is that we have the this unusual effect where even after 28 days of abstinence, we don't see a rebound to normal in executive functions. In fact, sometimes they're worsening at that point, and we need to study that further and for longer durations. But that's where we've seen age of onset of really daily use, you know, not intermittent use, to really be a very important factor. Yes?
Do you see it for multiple ethnicities, and if so, do you see any ethnic-specific differences?
We don't have enough of a sample to really answer your question about ethnic differences. We always do have representation of Hispanic and African American, Asian. Sometimes we even have Native Americans, but it's always in very small numbers, where the only real comparison you can do that really isn't worth very much is white non-Hispanic versus, you know. So I can't really give you much information about ethnic differences, maybe with a bigger sample.
And there's no single example of anyone ever becoming addicted to gabapentin, right?
Not in our hands. We had an active discussion about that at the American Academy of Addiction Psychiatry meeting, where someone raised, hearing that report in the penitentiary, that gabapentin was a valuable drug in terms of the black market in this penitentiary. And the discussion was that that was like an isolated phenomena where a placebo could have had the same effect just because of the novelty of whatever. But we've not had any incidences of people losing their drug and requesting replacements. We don't show any evidence of drug substitution and thousands of urines collected. You know, we don't see them changing to a different drug. We don't see, when we ask the drug liking and wanting questions, you know, we don't get a difference from placebo. It's just...
Is there any knowledge that they're on drug? Do they know whether they take
No,
gabapentin?
they don't.
There's absolutely no psychoactive effect.
No, we asked them at the end of the study which drug they thought they were on, and both placebo and gabapentin, you know, by chance, you know, no difference in terms of their ability to detect which drug they were on.
Because that's one of the problems with the antidepressant studies, right? They always know that they've gone on the antidepressants.
Well, because of the side effects. In
Yes,
beginning.
the side effects, yeah.
Right. So,
So
and
it's not
so,
really
so they didn't feel any strong side effects to make them guess.
No, there's no side effect that really pops out. The one thing that I like, and you'll see this in the alcohol too, you know, the side effects are collected by a completely different process than the Pittsburgh Sleep Quality Index. But, you know, you do have the more complaints with the placebo of insomnia than you have with the gabapentin, but not statistically here. These are side effects that people offer. You know, it's an open-ended question. Have you noticed anything since your last visit? You know, and you know, you get the usual kvetches, cold symptoms, muscle pain, so that's what you get in response, and really no difference from placebo. So what I'd like to do now is show the alcohol data, but I have to take this off.
Just take it off.
Take it off. Okay. Oh, that's the last of them. Okay. So, just to remind you that we started with alcohol, okay? And we got our signal in the alcohol Q reactivity. So, we did get R01 funding to do a large alcohol, relatively large alcohol study on the basis of a Q reactivity study. And that's really appropriate. You know, we had the animal models in George's group by Marissa Roberto showing gabapentin effects in alcohol dependence. We had our proof of concept human laboratory model showing a signal for alcohol dependence. Time to go to a randomized controlled trial. I think that's what we have proposed. So we had funding for 150 slots. Only this time, instead of sticking with the 1,200, we did the lowest approved dose and the highest approved dose. Because what you're always looking for is the minimally effective dose and the maximally tolerated dose. I mean, you want that kind of information. And you know, drugs cost money, so a minimally effective dose is a good thing to know. So, same deal, you know, no other medications, medically healthy, etc., DSM-4 criteria for alcohol dependence. So, this is the answer to your earlier question. These are the rates of complete abstinence. In the clinical world, number needed to treat is a measure of effect size. It gives you an idea of how many people you need to treat in order to get to the ideal effect of the drug. And you're often used to double digits. So a number needed to treat of 8 for the 1,800 milligram group is a good thing. And, you know, a significant linear dose effect. Number needed to treat for no heavy drinking at all over the 12-week study was 5, which is a very nice effect size. And what you have here is about half of the population of people randomized to the 1,800 milligram dose not having a single day of heavy drinking over a 12-week treatment period. So that's a very nice outcome. And the complete abstinence is not having a single drink over the 12-week treatment period. And these are really active alcoholics who had trouble putting 3 days of abstinence together before starting the trial. And I did insist on 3 days of abstinence. We all know why at this point, right? Because if they're drinking, if they're actively drinking, there's not that pharmacological target for gabapentin. And because I had the traumatic experience of being the overall principal investigator for the U.S. acamprosate study that was done in support of FDA approval for acamprosate. And people thought acamprosate was bulletproof at that point. I think it may have had 1 out of 18 negative trials. And the FDA said, oh, in the US, we don't have detoxification like you do in Europe, so you can't require that people be detoxified. And our modal alcoholic is a polysubstance user, so you can't exclude illicit substance use. And we're like, okay, that's not the way acamprosate works. But we didn't know that then, you know. It's like the mechanism literature hadn't caught up with the clinical trial literature at that point. And there were so few people who were abstinent starting the acamprosate study that, you couldn't even do a subgroup analysis of people who were abstinent. But fortunately, we had a measure of motivation, like what your treatment goal was. Did you want to be abstinent? Or was controlled drinking your goal? Or did you just not have a goal? And so at least identifying the subgroup who had the treatment goal of abstinence allowed drug placebo differences to be shown in that group. But, you know, I learned my lesson the hard way. If you think a drug acts by normalizing some neuroadaptation associated with abstinence, you better make sure that group is abstinent when they start that clinical trial. So this group started with 3 days of abstinence. And when you look at the weekly measures of drinks per week or number of heavy drinking days per week, you do still see the linear dose effect. And here you get, you know, a really good look at the variability and, you know, but then you appreciate when you see this, you know, how, you know, there are people who are drinking or, you know, having a day. That earlier slide of the people who had no drinks, no heavy drinking, you know, that this is a nice accomplishment. And
Were
then
all
when,
of them in homes that they had access to it and they had family members that were drinking as well around them?
yes, this sample was recruited exactly the same way the marijuana sample was recruited, with the same charming ads in the free paper, you know, and called the reader, and people would call, and you know, one thing. Oh no, I don't have it here. We had a really high ratio of randomized. We had 185 intakes to randomize 150 subjects. It was really very liberal admission criteria, and you know, people would call. We'd do like a little phone screening to make sure that they were likely to meet eligibility criteria that come in, and I think 16 were interested when they learned what was involved in the study, and others either had dependence on cocaine, that was a common thing, or whatever, but still, when you randomize 150 out of 185 intakes, that's, you know, a good generalizability of the sample. They all were community dwelling, they all were self-referred from the reader, newspaper, you know. And one other thing that I get asked about this sample is, like, how did you get 3 days of abstinence? Didn't they need to be detoxed? Well, people who are living in the community, who aren't coming from an inpatient unit or whatever, are usually drinking about 5 to 6 days a week. You know, they do have abstinent days. So with monitoring and advice to cut down systematically, they really do not need formal detoxification. And we use an instrument called the Clinical Withdrawal Assessment Scale to go through the vital signs, the history of withdrawals, you know, to really assess the risk. So we're very careful about that. And actually, nobody on this study needed to be formally detoxified with medication using the criteria of the withdrawal assessment. So just like in the human laboratory study, you had the greatest effect on sleep with gabapentin, 1,800 milligrams relative to placebo, with the 900 milligrams being in the middle. You had a much greater reduction in craving with the 1,800, and also the Beck Depression Inventory, just like in the marijuana study, showed the effect on gabapentin relative to placebo.
When we look at those curves, I'm not used to looking at this type of data.
I'm sorry?
I'm not used to looking at this type of data
Okay.
at all, but when I look at that, it looks like by the end of the study, the lines converged again.
Uh-huh.
So like what's going on there, I see like there's clearly a significant difference out to about week 8, and then it seems like the control is converging with both doses. And so how do you, I think I saw that on the previous slide too, so how do you interpret that? And is it because they're trying really hard over these 12 weeks and you get a head start when you're on gabapentin, or you know, how do you think about that?
Yeah, I think that what's going on is you have people engaged in 12 weeks of treatment who are getting counseling, and the system, the protracted abstinence symptoms, and the recruitment of the stress systems are, we don't know, they're not on a calendar. You know, in some cases, they will resolve. It's really the early period that you're at greatest risk for relapse and when the symptoms are the highest. And that's why it's really important to have the pharmacotherapies developed, available, and able to be implemented early on, because it's such a precious thing. There's so many alcoholics. There are 8.4 million alcoholics, alcohol-dependent individuals in this country alone. Less than 1% have ever been given a prescription for any alcohol-specific medication. And when you think of how precious it is for one of these people to recognize they have a problem with alcohol and they want to do something about it, and not to be given something that gives them this kind of a leg up early on in that process, you know, it's something that really needs to be addressed. And epidemiological data have shown that the longer you're able to maintain abstinence, the more likely you are to go on and have it for longer periods of time. And the reason we do the 3-month studies, because that is the most critical period. If you put your 3 months together, you're likely to get 6 months. If you put your 6 months, you're likely to get a year. And, you know, Alcoholics Anonymous has the anniversary celebration of their first year of sobriety. It's like they kind of got it early on, you know. So it is that kind of a process. Yes.
Mine's a similar question, but are the groups matched based on their goals going in, or is it completely randomized?
They're not matched on anything going in. And this is another thing that was found in the Comparative studies, and that is when you're using a medication that acts to restore balance in, you know, these systems that become the stress systems that become recruited by acute withdrawal and in protracted abstinence, you would expect, Chris, gets to your question, that the beneficial effects would be maintained if they're treated for an adequate treatment period, titrated off drug, they should go about and mind their business. And that's what we found, that the linear dose effects that were found during treatment were sustained post-treatment. And I'm happy to tell you, and the reason I signaled Chris we have to take it off is that this has been accepted for publication in JAMA Internal Medicine, which I'm really happy about, because that gets it to the people who are likely to actually prescribe it and possibly do something about it. They move the needle on that less than 1% getting treated. And so the follow-up data, you know, the effects lasting. You think of the outcome measures, the rate of complete abstinence, rate of no heavy drinking, number of drinks per week, and number of heavy drinking days per week. Significance was maintained when your dose effects for 3 of the 4 outcomes. I don't remember which one wasn't, but it was like 0.06, so it wasn't like it blew up or anything, you know.
And presumably they weren't smoking so much weed either.
So, just to summarize, the Cube Activity Proof of Concept study in the alcoholics gave us the signal for craving and sleep disturbance. The randomized controlled trial showed that we got significant improvements in drinking quantity and frequency and rates of complete abstinence and no heavy drinking. And remember, in the lab study, the craving is the marker and the predictor of the real world drinking. So, you know, that is congruent. And we got the congruent effects in sleep disturbance, and we also measured the negative affective symptoms with the BEC and the paper and pencil alcohol craving in the randomized controlled trial. So you really do have a good lineup of the lab and the controlled trial.
Since your subjects weren't abstinent, do they,
Is there any interaction between gabapentin and ethanol itself? Does gabapentin change the way the individuals feel when they drink alcohol?
No.
You look for that and there's no change.
Yeah, that was looked at. The other thing that's nice about gabapentin is that it's not metabolized in the liver. And you know the liver is an organ that's very responsive to alcohol. And also, by the time they get into treatment, alcoholics often have many other medical and even psychiatric disorders. So it's not likely to interact with other illicit or prescribed drugs. So it has a lot of benefits. One of the downsides is that it's an off-patent drug. There's no drug company that's going to get behind it and say, wow, we're going to get approval for alcohol, cannabis dependence, which are the two most widely abused substances around the world, because there's no financial incentive to do so. It's produced by many generic companies, and that's why it was important to me to get it published in a medical journal with some impact behind it, in the hopes that physicians would self-medicate and apply the findings. So, let's see. Yeah, I thought this was an interesting point that although noncompliance has been found to be a factor with disulfiram and naltrexone, our compliance rates were quite high, as confirmed by plasma concentration and return pill counts. And you think about this drug, it made them feel better. They're drinking less, but they're feeling better in terms of their sleep and their mood and their craving. And, they might be dependent on a substance, but they're not stupid. If something's making you feel better, you press the lever, right? So, I think that's an interesting detail to keep in mind. Parenthetically, if I may, I found a rather punitive, puritanical approach to treating people with alcoholism and the addiction in this country. They like punishment, things that make people feel better aren't as popular. I think the positive outcomes for gabapentin lend support to the role of neuromodulating drugs that target the dysregulation of brain stress systems associated with protracted abstinence and the treatment of alcohol dependence. And I said I was going to deliver the predictive validity. So if this Q reactivity model didn't show a signal for a campersate, that model would be in trouble. I wouldn't expect it to necessarily perform brilliantly with naltrexone. I really think alcohol self-administration is the correct model for a drug that reduces the rewarding value of alcohol. But a campersate should suppress the responsivity to alcohol cues. So we did do a study where we randomized people to 1 week of treatment with placebo, campersate, naltrexone in the standard therapeutic doses. And what we found was the placebo, had the highest levels of craving. Campersate performed very well on all 4 measures of craving. It, it performed better than naltrexone on relief craving. Everything would feel better if I just had a drink. That was way down with the campersate. And what was interesting to me is the effect that naltrexone had relative to placebo was feeling greater control over the impulse to drink. And the finding that has always been associated with naltrexone in clinical trials is not that you wouldn't pick up a drink, but that you wouldn't necessarily pick up the next 24 drinks. It's that reduction in heavy drinking. So it's interesting to me that out of the 4 measures, that one feeling more control over the impulse was associated with naltrexone. And I hate this slide and I apologize for it. Change scores are awful, but these are the change scores from baseline to after the 1 week of treatment. in the Pittsburgh Sleep Quality Index, and with placebo, you have some worsening of sleep. With naltrexone, you had a good deal of worsening in sleep efficiency, which is the amount of time actually spent sleeping that you're laying in bed, and in overall sleep quality, there was some worsening. But with acamprosate, you had the improvement from baseline, your decrease in symptoms from baseline on the various measures of sleep. And we've since learned through polysomnography studies that it's been shown to reverse alcohol-related changes in sleep architecture. So, acamprosate attenuated the reactivity to the alcohol cues significantly more than placebo across all 4 subjective measures. Naltrexone significantly improves subjective ratings of control in response to the alcohol cues. The physiological data were consistent with the subjective findings. And because of the findings with acamprosate, we felt that provided robust support for the cue reactivity human lab model to assess novel drugs for drinking relapse prevention in that protracted abstinence phase of alcohol dependence associated with the recruitment of the stress systems. Now, the last piece of the predictive validity work that we did with the model was to look at how it performed in treatment seekers who were on a 12-week clinical trial but did participate in the cue reactivity session. It was actually at week 2. This is a blinded analysis, and we don't know what drugs. I'll tell you, it's pregabalin, which is son of gabapentin, or duloxetine or placebo, but I don't know which group is which. And I will never do it again because even though they're in treatment, it did induce craving in some people. And if a clinician said, this person's too vulnerable, I don't want them to be provoked with the alcohol cues, I'm afraid they'll go out and drink. We didn't do it. So anyway, these were the scores on our 4 familiar questions, adding the questions together. One group, drug 1, had very high craving, and we hope that's the placebo group. And the other 2 groups had quite low craving compared to the blue group. And so the real question is, how will they perform on the clinical trial outcomes? Looking at the survival curves, time to first drink, that blue group that had the very high craving relapsed very promptly on the clinical trial, whereas the other 2 groups did much better in terms of time to drinking. Very similar to how the groups performed in the cue reactivity testing. And when we looked at all the different variables that are often associated or at least evaluated as predictors of outcome in clinical trials, such ages first drink, baseline level of the Beck depression inventory, family history of alcoholism, male or female, years of heavy drinking, baseline scoring alcohol craving questionnaire. None of those were significant predictors of outcome on the clinical trial. The Q session craving score was a significant predictor, and how much they were drinking at baseline was a significant predictor. Those were the only 2 predictors of clinical trial outcome. So our Q reactivity model demonstrated predictive validity for clinical outcomes and alcohol dependence relative to the published trials of approved drugs, particularly acamprosate, because that was the drug that we built our model to test. An independent trial of a novel drug, Gabapentin, 2 if you count the marijuana study, and the Q session at week 2 of the 12-week clinical trial of pregabalin and duloxetine. And we feel that human lab studies that are designed for a drug's mechanism of action may be useful in predicting clinical trial outcomes, at least guiding them. Remember the two earlier gabapentin human laboratory models, the non-dependent social drinkers, negative, alcohol administration design, negative, but Q reactivity and alcohol dependent, chronic administration for 1 week, you got positive signal that then did play out in clinical trials that were designed accordingly. And I think it's important to consider alternatives to alcohol self-administration. It has a lot of face validity in clinical trials of alcohol dependence. Well, let's see if it affects how much they drink. But if you're like really using what we know about the neurobiology of alcohol dependence and its effects on the HPA axis and the cascade of effects from there, and you're really positing that you're using a drug to unroll some of those effects, well then you don't want to see, let's see if it affects how many drinks they take. You know, you really want to see how it plays out in terms of prolonging abstinence and affecting that composite of symptoms of protracted abstinence, any one of which can be a trigger for relapse, whether it's the insomnia, the strong craving, or the negative affective states. Now the last thing I'm going to show you, if you have strength for it, this is a sneak peek at what we're working on now. With Mifepristone, the drug that George had talked about earlier, that's the glucocorticoid antagonist. And like George, I probably don't need to review it for you, that heavy alcohol use and withdrawal dysregulate the balance between the brain stress and reward systems. That's like a fundamental building block for our work. And that the abnormal HPA axis activity and glucocorticoid receptor feedback and sensitization of CRF in the amygdala are all factors that we kept in mind in our thinking about the Mifepristone. And as George reviewed for you, in Leandro Vendomusculo's work in his lab, it significantly re-induced reinstatement of ethanol seeking and intake both during acute and protracted withdrawal. Post-vapor, like days, I think it was 21 through 33, post-vapor exposure, he got an effect on consumption in the dependent rats and not in the non-dependent rats. And so we hypothesized that administering Mifepristone following acute withdrawal might normalize HPA axis dysregulation and protect against relapse during protracted withdrawal, using the same model that we did for the earlier studies. And we used the 600 milligram a day dose, which has been the dose that's been studied most commonly in our acute activity paradigm. And Mifepristone is one of the few drugs that I come across where plasma level has an association with outcome. That's been fairly well established in the psychotic depression literature, so we decided we'd look at that, and as well as the effect on cortisol, and of course the response to alcohol acute craving in the lab. So we gave the 600 milligrams for a week and did the Q session on the last day of dosing, but then we also extended our follow-up period to 1 month off drug to see if the effects on craving would translate into effects on drinking when they were out in the real world. So on this slide, this is onto one of our ancillary measures of compliance, because you'll see their cortisol levels in the Mifepristone group in red did not differ from placebo before they were given the drug, but after 1 week on drug, they had like a 5-fold increase relative to placebo, which 1 week off drug was going down, and by 1 month off drug had returned basically to normal. And it's been described as resetting the HPA axis, where there's this influx of cortisol that then you have going back to normal, and it's sustained for prolonged periods. That's how it's been described to function in psychotic depression, where it's been studied rather extensively. And so what we found is that relative to placebo, there was quite a reduction with Mifepristone. This is the number of drinks that were decreased from baseline relative to placebo. It was sustained the 1 week follow-up off drug, and at 1 month off drug, the Mifepristone group still showed a greater decrease from placebo in their drinking. And these are non-treatment seekers. They're not getting any counseling. This is nothing other than Mifepristone effects. And when we looked at what predicted that decrease in drinking that I just showed you in the bar charts, their performance on the cue-induced craving, the difference between their baseline and follow-up cortisol levels and the Mifepristone plasma concentration, all contributed to a model that accounted for about 85% of the variance in decreased drinking. Very benign adverse event profile. This includes both the week on drug and the week off drug because it has a long half-life. The most common adverse events in the literature are dry mouth, occasional nausea, and rash. The rash was rated in one case. The rash did not occur on drug. It occurred the week off drug, but I counted it because of the half-life. In one case, it was rated as not related to drug by a blinded study physician. In one case, it was related as possibly related. But I'll tell you that one of the guys was in a paintball party, didn't take a shower for 3 days. When he took a shower, he saw a rash. He didn't even think of the drug. He thought, oh, it's a pain. I should have taken a shower. And anyway, it cleared up without treatment. But this is our population, and no signal at all for abuse potential in terms of its resemblance and its subjective effects to other drugs of abuse. And so this is a drug that really puts its finger right in that system as a glucocorticoid antagonist and was associated with a significantly greater reduction in drinking than placebo. Was predicted by the Mifepristone plasma level, the cortisol level, the change, and the cue-induced craving. Sex, age, no other baseline variables predicted the drinking outcome. It was very well tolerated. Half of the sample reported no adverse effects. Nothing of any significance. Compliance was high, as you could tell from the cortisol and the Mifepristone plasma levels relation to outcome. And we felt that combined with the preclinical and human laboratory results, it has therapeutic potential for alcohol dependence. The results persisted post-treatment with no evidence of rebound following discontinuation. It was well tolerated. We had no concerns about safety, abuse potential, or noncompliance. Again, we felt the positive outcome lends support to the role of drugs that target abstinence-related dysregulation of brain stress systems. And like like with gabapentin, we failed to randomize a controlled trial to replicate and extend the proof of concept findings to treatment seekers with alcohol dependence was indicated. I must add gratitude to the National Institute of Drug Abuse for their support of the cannabis dependence work. The alcohol work was supported by NAAA and Pearson Center for Alcoholism and Addiction Research at Scripps. Thank you. Any other questions on top?
So if I can start, you have cannabinoids, you have alcohol with gabapentin. So do you think that it would work with nicotine, with everything else? Likely. So have we stumbled on one of those key nodes that modulates in general substance abuse, or do you think there is some pharmacological specificity to it that will make it unique for some drugs but wouldn't work for others? Just speculate.
In my alcohol sample, which was large enough to do what I'm about to tell you I did, I think it was 150, I was able to look at the subgroup who were also cigarette smokers. And we also got the effect on smoking in that subgroup of alcoholics who were also smokers. Okay, so you got effect on smoking. And what my thinking is that with drugs that have that profile of protracted abstinence symptoms that involve the sleep, the mood, the craving, that gabapentin will be useful. I think that alcohol, marijuana, and nicotine have, that gabapentin is sufficient to act directly on them, where you can see that rates of abstinence and rates of non-pathological use in particular are able to be sustained with gabapentin alone. I think drugs that maybe have a more driven form of addiction, like methamphetamine or whatever, I don't see gabapentin being a standalone treatment for something that, you know, I can't yet imagine a standalone treatment for. Any other questions? Yes.
So when you write this up for publication, do you recommend, I'm curious about the clinical side, do you then recommend a 3-month dose of this drug? Do you see this being something that people should be on longer term? Is it, or sorry, going back to the,
Okay, so for which disorder?
for the alcohol?
Gabapentin for alcohol?
Gabapentin.
Yeah. Okay, I think that's a really good question. The question was, what duration of treatment do you recommend? Yeah, 12 weeks is a really arbitrary period of time. And what I actually did once was a maintenance study where, with naltrexone and alcoholism, even I studied naltrexone, where I treated everyone with open naltrexone for the 12 weeks. And the people who benefited from it, who reduced their drinking at least 50% from their baseline drinking, or I didn't remember what my criteria were at this point, but maybe who had no more than 2 heavy drinking days a week. Some people who clearly showed that something beneficial was happening. It was at that point I took just the responders and randomized them to 9 additional months of treatment with either placebo or naltrexone. So essentially people had a year of treatment versus people at the 12 weeks of treatment. And we still had a significant benefit. Even though, you know, these were just responders and, you know, they had their 12 weeks. If you stayed on for the additional 9 months, you had a better outcome than if you stopped at the 12 weeks. So I think it's a very individual thing, you know, like when you stop treatment. The first year is the hardest, you know. I think getting through the anniversaries and holidays and, you know, everything with as much help as you can to not use alcohol, which has probably been a big part of those events, you know, I think it makes sense. I think AA has that first year anniversary of sobriety celebration for a good reason. I think the first year is hard. I haven't seen any downside to using gabapentin. I mean, people use it chronically as an anticonvulsant and for neuropathic pain. You know, it's hard enough to do the 12-week studies, you know, in our economic climate, doing maintenance studies. I ain't gonna happen, you know, but, so that's why I think it really is up to the astute clinician. And what people I used to work with real addiction psychiatrists, and, you know, they would even listen for dreams about alcohol or about craving, you know, and, you know, any signal that, you know, it was coming to the fore again, you know, it would be time for an increased level of treatment. You know, so we don't have a lot of science-based guidance in terms of how long to treat. I think your question is a really good one. George, I don't think we have any information about how long various stress systems stay recruited in protracted abstinence. I don't think we do in humans. You know, so there's still a lot of open-ended questions. But even, I think it's so exciting, you know, getting drug placebo differences and making traction in some of these areas, you know, that, you know, have really been very difficult to address, so that when people do bring us the gift of recognizing they have a problem and wanting to do something about it in one of these, you know, addictions, that, you know, we have something to offer them that increases the likelihood of meeting their goals. But it's still early days.
And the opportunities for longer treatments, right, in terms of pilot studies, could come from Europe, could come, in other words, from health systems where money is not necessarily the issue because you have public health benefits and whatnot. So you could set up those clinical trials in some places in Europe, and I'm sure that because of the novelty, because of the need of having treatments, we will make them very welcome, because you want to give patients something as opposed to just pushing them back out and give them no alternatives. And because of the health system is set up so that they would pay for it, there could be something that you can do there. So we'll talk about it later, but I have a few ideas.
Yeah.
And also the commercial side of gabapentin. I believe that someone could open a company, and several companies, one friend of mine actually in Italy made hundreds of millions of dollars just to create a drug company that makes slow release compounds for others, right? So he didn't invent anything, but I just saw his factory. As a matter of fact, a few days ago in Italy, he's doubling the size of these things, like a city now, because he just subcontracts drugs for diabetes and whatnot. And he makes these slow release compounds. So gabapentin is a perfect example of something that could be commercialized. And I think someone could make tons of money just to recycle an existing molecule off patent, make it into a slow preparation with slow release and so on. So that, you know, you could trigger some of your friends in San Diego, George, to invest money.
We have tried this, Anto. I mean, we have.
It doesn't work?
Well, we were approached by venture capitalists a couple of times. We tried to get Mark Pearson interested. For some reason, Mark Pearson has a thing about gabapentin. He read somewhere about those two people that they gave it to bipolar disorder and they had some adverse reaction. You remember, Barbara, you read that?
I can't even remember. You know, it's like a lay person who seizes on one abnormal finding in a vast literature and becomes preoccupied with it.
We had a venture capitalist who was quite interested, but at the end he basically felt that the commercial value wasn't strong enough.
Really?
But this is not unusual. I mean, every medication for addiction falls down this chute in the United States. I mean, you know.
Well, addicts also don't have any money to spend on the drugs, so if you're trying to make a profit off addicts,
This is
hard to do
an
it.
important observation, and it directly relates to what Anto is describing. Two things. Gabapentin, it's it's used pervasively, but I don't understand it because it has to be taken 3 times a day, which is awkward, you know? When we talk about, so a long-acting formulation is great, but it also then will have patent protection. And it will be brought forward to the FDA, because one of the problems with Obamacare is, as I understand it, is that it won't cover off-label use of drugs. And so even though I might put the results in JAMA Internal Medicine, well, Gabapentin's so cheap, believe me, it costs a lot less than what they're paying for buying their alcohol now. But still, you know, it wouldn't be covered as an off-label use. But a long-acting formulation would be if it's brought through the FDA for the indication. So there are lots of benefits to that approach.
Do you know, guys, who's in love with long-acting medications? Phil Skolnick. Phil Skolnick runs the medication development program at NIDA. He loves anything that is long-acting. He would go for it on any angle for any
Let's
disease.
use him
So-
as the test
Except for the
Yeah,
cat.
use him as the test guinea pig.
But if you talk to Phil about this,
No, we haven't talked about gabapentin. We've been waiting for Barbara to get the paper actually accepted.
because he might,
Because-
in general, he loves long-acting things. because he believes that, drug addicts
Who
are
is this
very
on?
volatile and they
Skolnick,
Oh,
Barbara.
Skolnick. Oh, okay.
Phil Skolnick, do you know him?
Yeah.
We know.
On the other hand,
Yes.
dramatically, on the other hand, I'm also very excited about the Mifepristone because it's a 1-week administration. That's it. I mean, you don't do more than that. And so my thinking is, if I've got effects, sustained, pure pharmacological effects in non-treatment seeking alcoholics, if you combine that week with really skilled alcoholism counseling and treatment seekers, that's a nice package for people who are not into medication. I mean, because this is a phenomenon that I see over and over again, okay? You have people who are pouring one of those big bottles with the handle on it of Ronrico down their gullets a day, okay? And you want to give them this tiny little pill. It's, oh, I don't want to take drugs. Right? I mean, well, you have to believe me. Anybody who works with the population sees this, So, there are people that I think really will do very well with long-acting gabapentin because they have that constellation of disruptive mood, sleep, craving symptoms that will prompt their relapse. But for people who need that, they just need a jolt and maybe some clearing of the cobwebs, because we do get effects on learning, memory, and executive function with the Mifepristone as well in the alcohol sample. And then dig into counseling. It's another modality, that could also be beneficial for a different type. Maybe a type that's not as driven by
Right, so do you
protracted
think
abstinence.
this might be like an intervention type of drug? These people that are not ready to quit, but that need some kind of help, some way to make them see that they do have a problem that's affecting them and their family.
Well, we're talking about a drug that's a glucocorticoid antagonist, so it is getting into that system that is dysregulated by virtue of the withdrawal and protracted abstinence, etc. And I do insist on my 3 days to get the effects that I get. But there are people who are treatment seekers who do want to make a change, but may prefer to do that change working, behaviorally, and that format, rather than long-term medication use. We don't know. It's worth looking at.
And the case you could make, because I do have some patients in Italy with Lyrica, with Gabapentin, which are very happy because of depression, because of chronic pain. So, you could really make a case that this could be useful to many different people. And Jessica, to go back to the issue of money,
large the market is. Do you guys know how much they made with Chantix? With
Oh, they make a ton of money with Chantix.
$700 million was just
Yeah,
the first
about
year.
800 million, and buprenorphine's now about $1 billion a year.
Yeah, so
Buprenorphine's been very, very successful, and no one talks about it. Truthfully, I don't know why Nora doesn't talk about it more than she does, because it is a NIDA product, basically. It's a NIDA success story. And nobody, I haven't seen anybody talk about it recently, but if you watch, the sales have been steadily going up every year. So there are two successes out there, buprenorphine and Chantix. They're both partial agonists, of course.
But the market is still, I mean, hugely untapped. Right? So you could make a case with anyone that.
I guess you can divert their funds from alcohol or cigarettes to these drugs to help them quit their habit, and then after a while they have discretionary money because they don't need either one.
But on an optimistic note, I think that as what we're all doing, what you'll hear all this week, starts to get more and more out to the public, and the public understands that we have targets. I mean, you're going to hear many more targets. There'll be a whole, you have a whole section on glutamate coming up, I'm assuming somewhere in the week. I think you'll see that as the information gets out, there'll be starting to be more and more of a demand that something be done, and maybe the pharmaceutical industry will come out of its great recession. So. Yeah, I mean, seriously, I mean, we've been in a pretty bad economic situation, and the pharmaceutical industry has completely stopped making psychiatric drugs, so addiction is just one of the players.
It's true. It's true. All of the pharmaceutical companies just dumped their.
They just dumped all their portfolios, and now that they're starting to creep back. Certainly in neurology, the anticonvulsants haven't ever lost favor. Parkinson's is still a big deal. Alzheimer's. So I suspect we'll see. You're not going to see any new antipsychotics, anti-anxiety drugs, or antidepressants in the next 5 years.
And Dr. Collins published a very nice opinion piece in Science, I believe it was, about how it's important to evaluate off-patent drugs for big unmet clinical needs, and which we did with gabapentin, but then you're up against, well, it's not going to be reimbursed under as an off-label use, and there's like a disconnect, it's one thing to evaluate off-patent drugs for big unmet needs, but then there has to be a path forward for people to be able to access them.
Eventually, Barbara, once you have the science that's backing you up, then someone has to go back to the legislators basically and say, you know what, cost and benefit. The cost of treating is like 50 times cheaper than not treating them and the cost of society. So it's, eventually we'll have to go back to that.
Well, there is actually a movement starting, burgeoning. I think they're starting in Denver. They came out to San Diego a couple weeks ago. It's being driven by Patrick Kennedy, who's the son of Edward Kennedy. It's called SAM, Smart Approaches to Treatment for Marijuana Addiction and marijuana problems. And so they're getting engaged. It's kind of grassroots at this point, or Kennedy roots, or whatever you want to call it. But he's a pretty big player. He's a former congressman from Rhode Island, and has had many problems with prescription drugs himself and depression, bipolar disorder.
When we have some senior staff meetings at NIDA, from time to time he pops in, because he comes to see Nora.
Yeah, he's on some advisory board.
Yeah, but he's very, very adamant about helping, substances. So, and he's a great speaker.
Yeah, so they're really trying to seed organizations across the United States to. Their position is not to legalize, but to decriminalize at the same time. So they want treatment. I think one of their main goals is to get treatment,
if your alcohol cohort were on marijuana, were smoking marijuana?
Chris asked how many of my alcohol cohort were on marijuana.
Not that many.
We don't admit
Almost
people
none.
who are dependent on other substances because we do such early stage clinical trials. We want it to be, specifically. However, NIDA, maybe other groups, maybe NIAAA as well, has the RFA out for studies of one dependence to study a comorbid dependence, and it's a good opportunity to study people who are dependent on alcohol and marijuana.
So that's the
Reaching
new
for impulsivity.
CRAN mechanism, right? C-R-A-N? No?
I don't know.
You don't know, you don't like CRAN?
I don't like that.
What good are you?
Nothing, that's why.
But I think there's a new mechanism, I don't know where the RFAs are. Are they out yet, Barbara?
Yeah.
They're out, yeah.
Yeah.
So you can tack, as I understand it, you can tack a $100,000 administrative supplement on to an existing grant, or you can go for a competitive supplement to an existing grant. There are two mechanisms.
And it can be preclinical,
So
clinical.
you can do, if you're doing alcohol, you can add nicotine. If you're doing nicotine, you can add alcohol.
That's good.
Yes.
So there's an evolving story with smoking cessation where stratifying on the strongly associated genetic variant and the nicotinic acetylcholine receptor gene is showing different efficacy based on that genetic variant. So are there any parallel stories happening with alcohol or cannabis where pharmacogenetic examples where stratifying on a genetic variant can give even stronger effects in subgroups or?
Yeah, there's a fairly well-established alcohol story with naltrexone now. Polymorphism and the I get the alphabets mixed up. OPMRI or R1. Yeah. That is associated with response. So I think when you have a mechanism that's quite specific for a receptor type, you have a better chance than like with the dirty drug, So I think pharmacogenetics can certainly have a role, but particularly with drugs that have a high affinity for a receptor that can be examined.
There's also a CRF
Yeah.
polymorphism
That's right.
that is predicted, I think, responses to stress in humans, but it hasn't been associated with any therapeutics, obviously.
Because.
No CRF antagonists available.
But getting with the money, of course, the problem with pharmacogenetics is that really narrows your population if it's shown to be more effective than just one subgroup.
But on the other side, it might narrow the population, but it might also permit efficacy to be shown that wouldn't be found in a larger population setting.
Yeah, I was curious because, so you say that gabapentin was initially for an anticonvulsant
Yes.
and neuropathic pain. So how did you make the link how did it happen to be developed for alcohol, or how did it come from being an anticonvulsant to something else?
Truthfully?
Yeah.
Yeah,
I'm always curious because most of the time it's random.
No,
so.
totally.
Yeah.
Talking to clinicians on the street
Yeah,
who
okay.
said,
No,
I've
but that's
never
very
seen anything work like gabapentin for my borderlines. When you hear something like that, it's like, wow. And, just clinical observation, really.
There was a clinician, a couple of them who said to us, we should try gabapentin.
Yeah, it's like fluoxetine, like 60 years ago.
So we gave it to the rats. We weren't going to give it to people. No, but that's how, you got to listen to the,
Clinician.
you really have to,
Yeah.
that's something that I think is really important to emphasize before I leave here, is that I think academia gets buried in rats and have no idea what it's like to interact with an alcoholic or an opiate addicted individual. And you should talk to them sometime, or listen to them or read some case histories. It's really eye-opening to find out that they're not rats. Okay, they really. The dark side is much more important clinically than I think you would be led to believe by academic studies in the neurobiology of addiction.
And I agree, because I've been persuaded by, and my original work was in depression and alcoholism, so like I've always had a sensitivity to, you know, the negative affect component, so it was very easy for me to move into, you know, medications that treat, you know, the protracted abstinence syndrome, and, you know, all the work that I showed you, you know, is on that end of things, but I still think the majority of the focus in addiction is on the front end, you know, the rewarding elements that might be important in the transition from use to abuse to dependence, but I think really it's what George calls the dark side, that keeps you maintained and relapsing and, you know, in that cycle after the dependence is established, and that's where my efforts have been focused, and I feel fruitfully so, because I think that if you do help people to literally feel better in terms of their mood, their sleep, their craving, in a benign manner, and they're reducing their consumption, you know, it's just win-win. You know, so.
Yeah, one more comment on that. I mean, heroin's a really good example, an opiate. So there was a huge article in the New York Times recently about prescription opiates in a town in New England. And they put a clamp down on the prescription opiate abuse, and what did the young people go to? Heroin. Why? Because of the old word, as I mentioned earlier today, hooked. You guys have no idea what it's like once you're hooked on opiates. You cannot get off opiates. They just completely take over your life. And I told the police chief in San Francisco this a couple weeks ago. They have a big problem in San Francisco with opiates because the people are all breaking into houses and cars and stealing cell phones out of people on the street to get the money for the habits. That's the big problem in San Francisco. It's not so much that they're worried about, you know, crime of murders and psychopathy. They're more worried about the fact that there's a dramatic increase in petty crimes associated with people stealing to feed the habits. It's not trivial. I mean, people don't take opiates because they want to tiptoe through the tulips. They're taking opiates because if they don't take opiates, they're really not feeling so hot. I call it the misery factor. It's not, you know, it's not really as sometimes it's portrayed in the academic literature, and I think that's important to remember what it's like to be hooked. So I like the old word, even though Roy Wise berates me for them. Next time I'll get him to define hooked.
In less than 3 pages.
In less than 3 pages.